Today we have got eminent endocrinologist, Dr. Rajiv Kovil from Mumbai, myself, Dr. Ajay from Kolkata. We are having a difficult time across the globe as the globe is slowly recovering from the metabolic as well as infective pandemic both together. It is really unfortunate as physicians that we are seeing lot many young people passing away at a premature age. From 45 to 65, we are losing people, and that is really painful as a physician. And unfortunately, probably infective pandemic is indirectly showing that how inadequately we are addressing our cardiovascular issues. Lot many patients having stroke, lot many patients having heart attack, they having premature coronary disease. Rajiv, what's your point? What is your take point?
I completely agree with my good friend here, Joy, that this has been a double whammy for all of us. We always had the diabetes and the non-communicable disorders epidemic in India, and then this viral pandemic hit us. And most importantly, for people like you and me, Ajoy, where we have been practicing for decades, we have seen a lot of suffering. But in the last 2 years, the kind of suffering we have seen, also, it's kind of hurt us. It's opened our eyes to so many things that we were not aware. Sometimes the absolute uselessness of us that we can't do much to what is happening. The premature death of so many of our patients, so many near loved ones, has actually opened our eyes that probably we need to get more intensive. The healthcare structure needs to get better. The health literacy needs to get better. One can't start swimming when you're drowning. You need to learn swimming much earlier. So this whole pandemic has been a wake up call for and healthcare people realize the importance of a structured care, importance of self care, and importance of being in the whole midst of a proper structured care given from top to bottom. So that's been a huge plus. What do you feel, Ajay?
So essentially what we mean, say for example, lot many patients, they do not visit institute. They prefer to have
Right.
individual physician or primary caring physician. So essentially probably you mean to say that we pick them early, we treat them comprehensively, and probably we treat them to the targets and look beyond the glycemic control. Probably
Absolutely.
whenever we are getting diabetic and hypertensive patients, we are looking into achieving their glycemic control or achieving the BP targets. Don't you feel that evidences that is coming up with a newer class of molecule are becoming compelling that we use them early, we include them for a more comprehensive care?
I completely agree. Is that pandemic and evidence has taught us that we cannot treat patients piecemeal. We need to treat them holistically. And our approach also, Ajay, in the last, I would say, 7 years to 10 years has changed. From being like cowboys chasing HbA1c, we have now robustness of evidence with certain drugs. And today we also focus on diabetes and the risk factors and the comorbidities that the patient has rather than just the HbA1c. And that has been a 360-degree change from earlier because earlier we were only targeting a good sugar control and add till we get to the target. Today we have multiple targets. Today we know that probably we can achieve better quality of life and improve the lifespan of the patient by using appropriate drugs based on his comorbidities rather than just chasing his blood sugar. So this has been a good understanding from all of us, and I hope all this percolates across, spans across into all kinds of doctors, and this finally reaches our end consumer, which is the patient, and he himself becomes a little bit more literate about himself, about treating himself, seeking attention, seeking guidance rather than from Google, WhatsApp groups, kitty parties, and breakfast discussion. The doctor's team, the healthcare team should be his point of contact for any kind of information, and that is also a part of our uh, advocacy and health literacy, I would say.
This is really something very important that you've been talking, that comprehensive health care not only depends on
True.
how we are choosing the molecule, but also choosing the point of contacts for the knowledge and guidance. Unfortunately,
Absolutely.
lot many patients drop. And in traditional way, when you used to depend upon molecules like sulfonylurea and used to up titrate blindly just to achieve the glycemic targets, probably unattended up titration used to get into hypoglycemia and catastrophic events, or patients used to down titrate. And probably these newer class of molecules like gliptins, newer class of molecules like SGLT2 inhibitors are coming with significant advantage in terms of weight gain, in terms of hypoglycemia risk aversion, as well as they are coming out to be effective as well as safe. How do you read? What will be your preferable combination of agents that you would prefer, which would confer on one side? Definitely, we will be looking for single pill combinations, because I understand
Right,
polypharmacy is a
right,
big
right.
issue for all of our patients.
Absolutely, absolutely.
So,
No,
what will be your molecules
I
of
think
choice?
you and me will both agree on one fact is that till date we have not been able to answer so many questions. Like when we stand up on a podium and somebody asks us, "Sir, what is a good blood sugar control to prevent chronic kidney disease?" And we will say A1C less than 7 or maybe 6.5, and but we don't say this with the conviction that we need to, because we've not had pharmacotherapy that could take patients to a euglycemia without hypoglycemia. So till the advent of the incretin based therapy followed by the SGLT2s, we were dependent on drugs which cause hypoglycemia. That is why we could never have a strategy of any trial. Like today, if we had done an accord and VADT with an SGLT2 plus DPP4 inhibitor plus metformin, maybe we would have had a different outcome altogether. So, a glycemic control strategy where we can target patients in euglycemia with the newer therapy like the DPP4, GLP1, and the SGLT2 on the background of metformin without hypoglycemia actually strengthens the confidence of you and me, and probably we could reach there with these kind of drugs, has been a huge boon for all of us, and probably we need to pass on this to the patient and the patient's benefit. What do you say, Ajay?
I think, Rajiv, you would also agree with the fact that over last 7 years, so many molecules came up with so much of data, but probably one particular molecule have shown the path since the day of empiric published in
Mhm.
September 2015. We've been talking about
Right.
mortality and mortality reduction and prevention of premature coronary disease. But don't you think that EMPA-REG and that persuasive p-values that we noted, that
Mhm.
hard in point of death reduction, all-cause mortality, CV death reduction, that really speaks volume about the robust data of EMPA itself. What is your
I,
take on it?
I completely agree with you, Ajay, is that there cannot be a harder endpoint than death. And if anything can reduce mortality, whether it's all cause or cardiovascular, then that molecule has a huge right upper place in our armamentarium. So statins were the basis of preventive cardiology, and I think SGLT2s are the basis of preventing diabetology or preventive metabolic issues, I would say. And the MPRS, with its benefit in cardiovascular death and its 3-point MACE, actually made us believe that what we have been thinking for very long, that probably there needs to be therapy in diabetes which can actually help patients live longer and prevent premature cardiovascular death. And that's the hope that EMPA-REG came in, and followed by a lot of studies from molecules in the same family, has actually built the strength of evidence that they have and the robustness of evidence in the last 7 to 8 years, that we are now fairly confident when we write these drugs, especially SGLT2s to our patients, that we are doing a lot of good to them. We are helping them in preventing cardiovascular events, preventing heart failure, sometimes treating heart failure, preventing progression of kidney disease, sometimes treating kidney disease. So we are doing a lot to them other than glycemic control.
So essentially, do you mean that with EMPA-REG and persuasive value of p-value that we have noted in terms of reduction of all-cause mortality, 3-point MACE, reduction of hospitalization for heart failure, and all these, are we essentially migrating from one age to another age? In 2008-9, we migrated from the era of sulfonylurea to the era of incretin-based regime. And down the line, 8-9 years, probably we migrated from era of incretin-based regime to SGLT2-based regime. Or we rather look into the synergy of the two classes, that incretins are complementing the action of SGLT2, minimizing their adverse effect, making them more safer,
Right.
minimizing genital things. What is your take on it? How complementing they are
I,
each
I
other?
there's a lot of complementary actions when we combine an incretin-based therapy and an SGLT2. The paradoxical high glucagon, which you see sometimes in the portal circulation when we do a chronic SGLT2 therapy, can increase the hepatic glucose output. And high glucagon is a pathophysiological defect in type 2 diabetes. So incretin-based therapy addresses this, and the combination of it, there's a lot of synergy in action. We also have data to suggest and real world data to suggest also that probably the mild increase in urinary or genital tract infection that we see with SGLT2s also goes down when you combine them with a DPP4 inhibitor. So all in one, both these drugs combined together, one, the DPP4 comes with the promise of no drug to drug interactions and very placebo like side effects. SGLT2 comes with the promise of robustness of evidence in reducing cardiovascular events, cardiovascular death, prevention of chronic kidney disease, and treatment of heart failure. So when we
Uh,
combine these two drugs together, apart from the glycemic benefits you get a lot of organ related benefit. You require get a lot of protection, end organ protection because of these combination of these drugs, and most importantly, you are able to prolong life of these patients, and that by itself is a huge feather in the cap of combinations. If you come down to combinations of DPP4 plus SGLT2 inhibitors, and especially combinations which have a lot of evidence behind them. A lot of combinations are being made in India, and we need to support evidence-based combinations, and that in the longer run, because a few bucks saved here doesn't make any difference. Because at the end, we need to make sure that these drugs are for long term. We need evidence of long term and durability of control and protection of end organs long term, and that is the promise that these drugs come with.
so essentially, you would endorse my view that single pill combination of Empalina, because both have got very robust nephro-safety data, complementary actions on renal protection, proteinuria reduction, delaying the progression of end-stage renal disease, as well as cardiovascular mortality-related issues. So,
Mhm.
would you also consider early adoption of even earlier than metformin? You mean to say, if a person is intolerant to metformin, maybe even earlier than metformin. So, are we essentially recommending use of this single pill combination for those who can afford? Definitely, in terms of mortality reduction, the long-term survival issue-wise, this affordability is definitely something we need to understand, rather than the cost of treatment being compromised with the cost of price of the tablet itself. What is your take about it? Should we understand the disease on a larger canvas and adapt the molecules in a way which is supported by the evidences and which improves outcome?
I completely agree that probably we need to have that canvas for every patient. I hope we could have genomic sequence and some kind of an astrology practice, or where we could tell patients the kind of dangers they face. Because every time you talk about any kind of comorbidity or complications, patients feel that you're actually trying to scare them. But the reality is that a lot of features in diabetes trigger the epidemic of cardiovascular disease globally. So essentially, the job of metabolic physicians is to make sure that you are able to postpone premature cardiovascular events and, if possible, prevent that. And from that scenario, and if that is the mission and vision that most of metabolic physicians have in mind, then these drugs come into being in a very, very big way. And as you said, that we need to impress upon the patient the benefits of these drugs very early. And If the patient has very high risk for any of these complications or is established, I would start them very, very early directly onto a drug naive patients also. And I have a few patients and a few colleagues who are doctors who have opted to be on these therapies rather than the traditional approach of sequentially adding on after metformin fails. So I think in India, where follow up is very poor, patients are lost, patients are fed a lot of unstructured news from various sources. I think we have to do the best practices in our clinic, and that best practice would be that these two drugs need to go up the ladder and be offered much, much earlier than most other therapies. That at least a few percentage of patients who take them for long term and who continue taking them for long term will eventually have risk reduction in their cardiovascular and kidney outcomes is what we can do in the limited perspective and the limited influence we have as far as the profession goes.
Very nicely mentioned. Very nicely mentioned, Rajiv. Just last couple of questions. Very small couple of questions. We often talk about cardiovascular safety and cardiovascular superiority as a class effect of all SGLT2 inhibitors. But the VATISI we have categorically shown that etugliflozin failed miserably to prove that beyond heart failure thing, it can go anything other than that. And dapagliflozin studies that whatever we had, or canagliflozin studies whatever we had, could never achieve either any benefit in terms of prevention of death, severe death reduction, or at the same time they failed miserably to document any effectiveness in heart failure with preserved ejection fraction or intermediate risk factor. Do you think EMPA retains a superiority, and that's how it is beyond the SOSTA DAPA and the class that way? Do you think this
I,
EMPA stands ahead?
I completely agree with you there that the robustness which EMPA has shown in all the whole cardiovascular continuum, whether it's 3-point MACE, whether it's cardiovascular death, whether it's heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, we have robustness of data there, and it is almost linear except a few where we did not get cardiovascular death, but if you look at Vertis TV versus Emparec, the population was the same. It was very surprising that the outcomes were completely different, which again says that we cannot call it as a class or family effect. Each drug needs to fight for its labeled indication based on the evidences that we have. And today, based on all the SGLT2s available, the level of evidence and the credible evidence which EMPA has, nobody else has. And that kind of evidence itself propels empagliflozin right on top of all the SGLT2 inhibitors. And I think that I would go one step further and say that if a patient has cardiovascular disease established or is at high risk for cardiovascular disease, chronic kidney disease, or heart failure, as in the newer definition of pre heart failure, I think it's morally and ethically wrong on our part not to offer these patients
Absolutely.
empagliflozin or other SGLT inhibitors. It is
Uh,
ethically wrong on our part not to offer them. They don't want to take it, it's a different issue. But I think we have to give them the sound understanding of the drug and offer it to them. And that is what evidence based medicine would tell us to do. And I think rightfully all of us should do that also.
And up to what level of EGFR we should go? Because often our PCPs have the doubt that these patients have compromised renal function. Though we have seen patients' renal function improves after introduction of SGLT2. Up to what level can we use it?
Ideally, 30 for DAPA and 20 for EMPA is fair enough to be taken.
So essentially, you mean to say that EMPA has got a better handholding even in lower EGFR range. So essentially, what we could hear from Rajiv and what we could hear over our small talk, that essentially, if you are looking for organ protection strategy, we are trying to minimize cardiovascular events, be it stroke, be it heart attack, be it heart hospitalization for heart failure, or all-cause mortality reduction. And at the same time, if you're looking for end organ protection strategy in order to prevent the progression of end-stage renal disease, stroke prevention, and if you're looking to protect the peripheral circulation as well, because
True.
Canagliflozin shown unfortunate data with higher risk signal for amputation. So, what will be a concluding remark, Rajiv? What will the concluding
Um,
remark for the use of the whole?
I think that one, somebody had asked me just 2 days back that what is the right fit patient for a combination of SGLT2 and DPP4, and mine was that almost every patient who walks into my cabin, if somebody, every patient with diabetes, especially in India, has loaded his, what do you say, his hereditary gun with a lot of risk factors, and the circumstances, the stress that we as metabolic physicians give them the right therapy. And I think the SGLT2 followed by DPP4 inhibitor with metformin in the background should be offered to all our patients to make sure that we are able to, as you know, there is this slogan that we are the diabetes capital of the world, but we can make it also the diabetes care capital of the world by adopting these evidence-based drugs with the robustness of evidence in almost all our patients. Thank you so much, Ajoy, for being a fantastic co-host and very warm exchange of communication between us, and hope I see you soon in Calcutta.
Thank you.